Hi, welcome to another episode of Girl Talk. Today, I am joined by Dr. Katie Barber from the Oxford Menopause Clinic, a private clinic in Oxfordshire. So, Katie, welcome. Thank you for joining us.
Thanks, Kat. Nice to have you.
And I'm having so many questions about HRT, testosterone, and so I thought who better than to bring you along, Katie, to answer those questions. So first, Katie, tell us a little bit about yourself and your journey and why you're specialising in menopause.
Great, thanks for having me. So I'm a GP first and foremost. I underwent my GP training, but had a real passion for women's health, which started back in my medical school days and was sort of developed by my GP trainer, who was a gynecologist. And then I worked alongside the urogynecology, gynecology and menopause teams at the John Radcliffe for many, many years before running the menopause clinic at the JR in Oxford, which is sort of a secondary tertiary referral centre for complex cases, women with early menopause, women who may be struggling with menopause treatments and it's not resolving things.
Right.
And then about 2 years ago, I became clinical lead for the community gynae service in Oxfordshire, which is kind of an extension of primary care. And we again see women who've maybe need a little bit more specialist expertise about their menopause. And I work now as a GP, I work in community gynae, and I launched my private clinic about 20 months ago now, and it's going from strength to strength, enabling more and more women to access me for specialist menopause advice.
Fantastic. Okay, so one of the questions I'm always asked, first of all, what is the difference between body identical or bioidentical HRT and then body identical HRT?
Great question. And there's a lot of confusion actually among patients and medics about this. So body identical HRT is really probably the gold standard type of HRT we can prescribe safely. This means it mimics the natural hormones we produce. So molecularly, they're identical to estrogen, progesterone, and testosterone, which are the three key hormones women produce. The difference with bioidenticals is that body identicals are regulated, they're approved, they're licensed, they're researched, there's evidence-based to support their use and safety in the NHS and privately. But bioidenticals are slightly different. These are often precursors to hormones, which are then metabolized into those key three hormones. They're not licensed and regulated in the same way, and the evidence to support their safety and efficacy is maybe not as vast as the body identical regimes. There's certainly been a shift towards more body identical hormones over the last 2-3 years because they're very safe. So because they're naturally occurring hormone products, their efficacy and their risk benefit profile is superior to a lot of the standard tablets we're used to prescribing many, many years ago.
Okay. And are they both available on the NHS, or are some only available to patients who can afford to go private?
So all the products I prescribe in my private clinic, bar one, are available on the NHS. There are a couple of body identical estrogens that have recently been approved for use in Oxfordshire. And this is where I'm desperately campaigning to try and get a national formulary for HRTs so that there's equal access to HRT products across the country. Some areas will approve certain products for use over others. In Oxfordshire, we've really pushed this through so we can have literally everything at our fingertips. So apart from Androfem, which is a testosterone product that's it's just not used in the NHS but used privately, everything else is available both on the NHS and privately, including testosterone. There isn't a female licensed product of testosterone available in the UK, but we use male products at very low doses, so it achieves the same result on the NHS. It's just we don't have the specific female product.
So women can get a testosterone product on the NHS, because that is a question so many women are saying their doctors aren't prescribing testosterone.
Yes, they can. There's, nice NG23 guidelines said women can have testosterone if HRT doesn't improve sexual function adequately. We use I'll show you a couple of products. So we use this product, which is called Testim, and then there's Testa Gel, and there's also a pump action. There's lots of testosterone products designed for men, and the dose is very, very high. So we have to modify those to women for women to use at appropriate doses. But yes, they are available on the NHS. The current guidance is that actually they should be prescribed by menopause specialists or doctors with enough expertise to know how to do that prescription safely and appropriately. Which is often why women are told, no, you can't have it, because a lot of GPs don't have that training to prescribe, but there will be a clinic they can refer to for that prescription to be actioned.
Okay. And then what about the different types of HRT, whether it's gel, patches? What do we have available?
Oh, well, at the moment, I'd love to say everything, but there
Yeah,
isn't.
sadly, no
Which is,
shortage.
I had my clinic this morning. I said I feel like a plumber without their toolkit, because all the things that I'd love to be able to prescribe are in short supply. So transdermal estrogen going through the skin, so that's a gel, a patch or a spray, are the safest forms of estrogen we use. They don't increase blood clot risk. They don't increase stroke risk. They also don't interact with other medications to the same degree as, say, a pill form of estrogen. And they are the ones that a lot of women will prefer to use for their safety and risk benefit profile. So we use products such as gels. I've got a couple here to show you. So there's this is called Estrogel. Sorry if it's out of focus slightly. And then there's a little sachet called Sandrina. These are equally the same. They produce a gel form of estrogen. They deliver 17 beta estradiol, which is the body identical estrogen form. You can also get a spray called Lenzetto, and you can get patches. Now, they might be different brand names, Everel, Estradot, Estraderm, you name it. There's lots of different types, but they're all delivering body identical estrogen to women at different doses.
Okay.
There's also tablets. So tablets for a lot of women are appropriate, are safe, and are the right option. And there's recently been a newer product on the market that combines body identical estrogen with natural progesterone, which is fantastically safe.
Okay, combined.
Yeah.
Perfect. Now, which is the one the gel that everyone is struggling to get hold of? That one, the white and blue bottle.
Estrogel. And I do know, I can understand why everybody really likes Estrogel. It's got a lovely consistency. It disappears on your skin. You don't have anything visible. You don't get that little sticky residue that you get with patches. It's really easy to apply. But there are lots of alternatives you can use in the short term if that's not available.
Okay, so what happens? What is, many of the women have been swapping from the gel to a patch and then struggling.
The difficulty is absorption is so variable. Some women, I spoke to a lady this morning who was getting really obvious red square when she peeled her patch off, and that's just classic skin irritation from the adhesive. And then the estrogen doesn't penetrate through that inflamed, itchy skin. Sometimes trying a different patch brand can help, trying a gel, trying a spray. Just rotate through whichever products you can obtain to get the right treatment for you and get that absorption improving.
Okay, and how long would it take for women to see significant changes from taking HRT? I know every single woman is different, but what would you say? So if a woman swaps to a different brand,
you can actually, if you're really stable on a particular product and you change, the difference, if it's going to be adverse, can happen quite quickly. So within a couple of weeks, up to 4 weeks. I've seen a lot of women saying, look, I'm using a patch now because my gel's not available. It's just not as good. There's a rough equivalent to doses. So if you're using a certain number of pumps, there's a certain size patch that you should have, but it's not exact. So women absorb differently from different products. So when I guide women, I'll say, look, I'm converting you to what is the rough equivalent, but the absorption is variable. So classically, women will find recurrence of sweats, flushes, not feeling as well, return of that joint aches, pains, brain fog, fatigue with too little estrogen.
okay.
But conversely, breast tenderness, headaches, nausea means you've gone a bit too high.
Too much.
Exactly. And if you just jiggle it around to suit you and cut back or increase, it has to be done carefully. It's not exact, and you just have to adjust according to each woman's response.
Okay. Just another question on, so many women are told they can't take HRT. Maybe it's due to having, had cancer in the past or due to blood pressure. As I know you can't tell us everything, but what is the rule of thumb as a specialist?
So the bottom line is there's very few women who can't take HRT or should be not advised to take HRT. Usually it's the hormone sensitive cancers. So that's the majority of breast cancer, certain types of ovarian cancer, and womb lining cancer. These are cancers where we hope that women have had treatment to effectively cure them and reduce the risk of recurrence. And if we feed those stray cells that may be left behind that the body's beautifully keeping under control, if we feed those cells with estrogen, it increases the risk of us having a recurrence of that cancer, which is not what we're wanting to do. But there are certain types of women who choose to take HRT despite those risks for quality of life. If you've recently had a heart attack or a blood clot or a stroke, it's a really good idea to modify any risk factors that cause that event in the first place before you then start HRT. So that might not be a no, you can never take it. It might just be not now, but let's get that sorted and move on. There's a few patients who've maybe got significant liver disease or certain medications that could interact with different types of HRT. And I would always have a joint discussion with their specialist, the liver specialist, or their consultant in a different speciality of medicine, just to check that what I want to do to try and make their menopause better isn't going to have an adverse effect on their other medication or their other health conditions.
Okay, thank you for that. And another question, you know, women, so many women are going to the GP and they're being told they're too young to be menopausal or perimenopausal, often antidepressants. How soon can women, if they choose to go the HRT route, when should they start taking it in perimenopause? Is it what type of symptoms would?
Sure. So, I mean, under 40, you really need diagnostic blood tests to say this is premature ovarian insufficiency. This is ovarian failure at a very young age. Over 45, blood tests are really often not helpful. So for women over 45, no problem. If you've got menopausal symptoms, which could be anything, it could be your classic hot flushes and sweats, but more commonly I see, you know, fatigue, lethargy, insomnia, joint pains, vaginal dryness, sexual dysfunction, memory impairment. All these symptoms are a lot more pronounced. If you're over 45, you don't need a blood test. We would just treat you. But more and more women sensibly coming forward now between 40 and 45 and saying, do you think this could be perimenopause? And certainly for the majority of women, providing there's no clear contraindication, a trial of HRT is not harmful as such. And a lot of women will then know what's driving their symptoms. The difficulty with symptoms like fatigue, insomnia, mood changes is that they can be multifactorial. There's lots of different causes, I'm sure you know. But sometimes I would say, look, there might be a hormonal element. Would you like to try some hormone therapy? We will then know if that's optimized, whether or not if there's some other issues contributing to the way you're feeling.
Okay, that's great, Katie. Thank you. What should women be saying when they go to their GP, you know, if they're not getting the help they need?
Do your research first of all. I mean, I think it's, you know, GPs, and I'm a GP, are jack of all trades. We have to know a little bit about everything. And although I'm a menopause specialist, and if I get a menopause consultation, it's a delight because clearly I know everything that I need to know. But likewise, if I don't know the answer to a problem, if it's say a cardiological problem or a liver problem, I'll go and ask for help. And I would encourage you to take information to your GP about your symptoms first and foremost. There's some fantastic questionnaires online. There's some apps out there that you can get information from and download and say, look, I've tracked these symptoms. This is what's going on. Or go armed with information from resources online. The Women's Health Concern, which is the patient arm of the British Menopause Society, is fantastic for information. My website, your website, we've got fantastic resources at our fingertips now, thanks to the internet, for women to really feel that they're empowered with that knowledge to go and ask for help.
I think that's one of the biggest things women I see is the amount of women that don't track their periods. So when I ask them, when was your last period? They haven't got a clue. So nowadays with smartphones, it's so easy to track your periods, or go back to your old fashioned paper diary or crossing out on the calendar, tracking your periods, so that when you do go to your doctor or your specialist, you could say when your last period was and know when you are post-menopause as well, but also symptom tracking.
Perfect. Yeah, absolutely. And you'll find often with perimenopause that you get sort of changes in those symptoms depending on when your cycle's happening. So using that information is key. Yeah.
And the symptoms can change depending, you know, one year you may have tinnitus or anxiety, and the next then it's the hot flashes. So it's tracking those symptoms and seeing what's causing them. Okay. Anything else you can think of, Katie, before we wrap up?
What I would say is I'm really delighted by the menopause revolution that's happening. I'm seeing so many more women between 40 and 45, but also older women who, I love the statement this morning. A lady said to me, she said, I thought I'd missed the boat, but now I don't think so. And I was like, brilliant. You know, she's 56, she's still suffering with menopause symptoms, but she said, actually, this isn't something I have to put up with. So my statement would be, it's never too late to ask for help, but it's also never too early. And even if you don't need treatment now, being aware of those symptoms and getting the right advice and support early on so that you're then armed with that knowledge is key. Yeah. And that's what's so good about this, you know, the movement now is younger women are starting to understand, and also men are starting to pay interest in what women are going through. So fantastic.
So thank you so much. I will pop Katie's contact details below if anyone needs to find out any more information. Thank you so much. And Katie, I'm sure we will be in touch soon to see what else we can do to help women.
Great. Thanks.
Okay, thanks for your time.
Thank you.